Thank you very much, Mar. And it's great to see everybody live and in person in this wonderful town this time of year. I'd like to thank David for the invitation to participate in this and Medistim as well. I'll try to zip through some of this so that there's some time for questions, because I know the value of this type of forum is really the interaction. The REQUEST trial was funded by Medistim. For me, I've been using transit time flow and the Medistim equipment for over 20 years in my practice. Transit time flow measurement and high-frequency ultrasound are well established and been around for well over 20 years for the assessment of graft flow. And it does complement the surgeon's technical prowess, but also the functional and structural assessment of both the operative anatomy, completed grafts, and perhaps intraoperative planning and staging. As mentioned by David and others in 2010 and updated in 2018, both the use of HFUS and TTFM are Class 2A level evidence for use of assessment of coronary artery bypass graftings. Transit time flow measurement, as indicated, measures both mean flow. It allows the diastolic flow and the pulsatility index. The pulsatility index, if you will, is both a measurement of the technical quality of the anastomosis, is also influenced due to some of the distal coronary bed as well. High-frequency epiaortic and epicardial ultrasound are very useful in allowing inspection of the aorta above that of manual palpation to help for cross-clamp site, cannulation site, or for perhaps proximal anastomosis. And the ultrasound is also great for utility in trying to find intramyocardial coronary arteries, assessing the anastomosis, as well as after completion or planning endarterectomy and target vessel location. The CREST study was performed at 7 centers, all with experienced teams in both coronary and cardiac surgery. All members of the operating teams were adept at both on and off pump, and it was also a pleasure to work and get to know many of the investigators. It was protocol-driven for the use of HFUS and TTFM, and it was used to assess the rates of surgical strategy changes and graft revisions. David elucidated some of this. The primary outcomes were intraoperative changes, and secondaries were specific TTF parameters and MACE events. And overall, there was a 25% change of planned surgical strategy, and this was broken down into changes to the aorta, conduit, coronary target, and grafts. It should note that of the changes that were made on the aorta, most or over 90% of those were driven by the use of the HFUS, and for the target coronary artery, it was both a combination of TTFM and HFUS. So in general, 25% required a change of surgical strategy. This was, as mentioned, at experienced cardiac surgery centers. And based on this, the recommendations or thought processes was that TTFM and HFUS may be used to improve quality, safety, and efficacy of CABG procedures and should be considered for routine usage in all coronary bypass graftings. What we did is to look at, in any study, there's going to be some particular patient population, subgroups, or areas of interest that are derived from this. And what we did, and what I give great thanks to my research group, and one of the members, Alex Peters, is sitting in the audience, and I worked with David, and we looked at particular areas that we thought might be of interest. Some of this is going to be discussed in other talks here, but we looked at the on and off pump group. If you see, 40% of the procedures were done off pump. Prior revascularizations, principally PCIs in patients, diabetic, non-diabetic, gender, chronic kidney disease, and then looking at the territory and the actual conduit usage and seeing if there was any further elucidation that could be driven from this. For the on-off pump sub-analysis, you see that the off-pump group, there was 4 times more likely to have a surgical strategy, and this was principally driven by that at the aortic site, and this was driven again by the use of HFUS, in which over 98% of those changes at the aortic site were driven by imaging from the HFUS. The on-pump group had more changes regarding conduits, and there was no difference in any of the MACE events between the two groups, and this is always something that's discussed in the literature, and of other significance is that there was extremely low cerebral vascular events in both groups, particularly the on-pump group. In terms of the territory, with over 3,000 anastomosis, over 50% were the anterior wall, about 30% to the lateral, and about 20% to the inferior wall. If you notice, overall graft revisions and surgical changes really didn't change among the group. However, with regard to the inferior territory, compared to both the anterior and lateral wall, there were more graft revisions to this interior territory, and this was driven by both the use of HFUS and TTFM at a rate of close to 70% over surgeon-experienced tactile or other type of methodology. Looking at the arterial venous, there was almost 60% of arterial conduits and 40% of venous. Revisions to the arterial grafts were more common than the venous at about 4.7 to 2.4%, and this again was driven by the use of both the HFUS and TTFM, which accounted for most of the changes for both conduits types. For the arterial revisions, most of these were due to primary anastomotic revisions due to a technical area, both at either a multi-arterial conduit or actually at the target vessel. Although this was not part of the initial intent of this study, we all know that renal insufficiency, failure, or end-stage renal disease pose a very complex group of patients. So our group looked at this particular subgroup. It was approximately 10% or 95% of the total group, so it was not highly powered, but there were some significant changes, and that we did find, not necessarily surprising, that those patients with chronic kidney disease or end-stage renal disease did have a more likely surgical strategy change, and this was driven both due to HFUS and TTFM, with the greatest difference seen in the graft revision rate of 7% to 3.4%. Diabetics are also another challenging population. About 40% of the total patients in this analysis were diabetics. And interesting for this, most of the changes in the surgical strategy was due to the aorta, and this was driven by the use of high-frequency ultrasound over any other modality in about 98%. And this was compared to the non-diabetics as well. It should be noted for the diabetic group that more radial arteries were used than bilateral internal mammary arteries. For prior revascularization, and again, the definition of this is principally PCIs. There were some redos, but most of these were PCIs. And of note, previous revascularized patients did have significantly more strategy changes. Again, this was related to the aorta in about 97% of the time. But again, even though patients with prior PCIs or multiple interventions might have more diffuse disease, that was the only significant change of surgical strategy for this subgroup of patients. With regard to male and female, there is, across all centers, it was only about 10%, and you might say, oh, the 10%, that seems low to my practice. Maybe it was because of the VA medical center where I am at and we contributed all males. Well, that's not the case, but that is a good thought. Regardless of that, women underwent fewer intraoperative strategy changes to the aorta, and this is interesting in contradistinction because there was a larger number of comorbidities and diabetes in the group with women. Of note for this group as well, there was, if you notice the changes related to the completed graph on the bar graph, you'll see no significant difference. However, in the female population, there was more significant graft revisions made in the off-pump group. So limitations then, there were no controls of patients not having this methodology. The study design was not specific for some of these subgroups, and it didn't capture long-term outcomes. Yet it was also performed with surgeons with a high experience of CABG volume or surgeons dedicated to performing coronary bypass grafting. In conclusion, I think surgical strategy changes made as a result of TTFM and HFUS are common, with systematic intraoperative quality assessment of the aorta and completed grafts is routinely utilized. HFUS and TTM, as mentioned before by other speakers, complements the surgeon experience to help navigate intraoperative challenge and achieve good clinical outcomes. Further studies are still needed to correlate intraop graft assessment with long-term outcomes. Specific situations, again, based on this analysis, would be aortic evaluation in off-pump or gender-driven, and then in multi-arterial grafts, particularly to the inferior territory, and then clinical features of diabetes, chronic kidney disease, or prior revascularization might be situations where you really would want to employ and check the validation of your grafts. Thank you very much.